Okay, Dr. Marc Schlosser is going to be our next presenter. He's amazing. If you haven't heard him before, he's definitely in our family now. So I'll let Dr. Schlosser take it away.
All right. Well, I am impressed that so many of you have stuck around. I was told this is a 2-day conference, so that's very admirable. It's always energizing to me to see people that are, that interested in substance use disorder. So what I'm going to do, I'm Dr. Marc Schlosser, and I am an OBGYN that has transitioned after retiring for a day about 5 years ago into helping with the addiction crisis in Palm Beach County. So I have been working in Palm Beach County. I work closely with the managing entity, Southeast Behavioral Network, and with the state targeted response. So I'm one of the experts that teaches around. So, if any of you have an organization where you would like one of us to speak like this, then, we're happy to do that. I'm currently seeing patients at a clinic in Delray and working with the healthcare district. And unfortunately, Jerome Golden, which was a mental health treatment center, was filed for Chapter 11 this week. So I am probably going to be working with some of the patients that were transferred from there. So I am a prescriber of methadone, buprenorphine or Suboxone, and naltrexone, the 3 FDA-approved medications, and we're going to go through all of that. So addiction is a very complicated disorder. It has a lot going on: physiology, behavioral, psychology, and the neurobiology. So I'm going to go through some of the neurobiology with you, but rather than use, technical medical charts like this to make it a little more understandable, I'm going to use illustrations. And hopefully that will make it a little bit easier to understand. So, well, actually, before I start, I just wanted to mention after the last panel that if you look at deaths from substance use, there are 450,000 deaths a year from tobacco and its related comorbidities, 90,000 from alcohol, and those two are legal, and 70,000 from opioids. So just keep that in mind, that we have this huge problem with the legal stuff, and so making more things legal doesn't necessarily help. Okay, so let's dive in. So if we look at the brain and we look at what's behind the forehead, right? And behind the forehead is the cerebral cortex. So the difference between humans and lower mammals, like a dog, is that we have a very well-developed cerebral cortex. And the cerebral cortex is where we do our executive thinking, our reasoning, and it really kind of allows us to be able to drive a car, which is very difficult and very complicated. Decisions have to be made all the time. And lower mammals can't do that except on Subaru commercials, where somehow they got the dogs to figure that out. But if you look carefully, they do back into mailboxes, but so do people. Okay, so very important that we look at the executive function and the reasoning of the cerebral cortex. And then we have another area deeper in the brain called the midbrain. And if you think of the midbrain as kind of like our CPU, our central processing unit, where everything automatic happens. So our breathing, our blood pressure, everything that keeps us alive all day, but we don't have to think about it, because obviously we had to evolve into that type of situation Or if you forgot to breathe, you fell down, or you forgot to have your heartbeat, you'd fall down. So that wouldn't work out very well. So this area of the brain, for better or for worse, is where we have an area called the ventral tegmental area, right? And if you think of the ventral tegmental area as a fuel tank, and that fuel tank is full of dopamine. And dopamine is a very important neurotransmitter that we have to have just to make us want to get out of bed in the morning. So any time we do anything that we like or we want to remember, we make dopamine. So dopamine is very critical in the addiction hijacking of the midbrain. Another area within this automatic part of the brain, the midbrain, is the nucleus accumbens. And I'm not going to give a quiz at the end of this, so don't pay attention to the names. It's just important that you have heard them. So the nucleus accumbens is an area where we have receptors. So those little U shapes, and unfortunately the pointer doesn't really show up on the screen, but those little U's around the nucleus accumbens represents mu receptors. So we have mu, delta, and kappa receptors, but the important receptor that we're going to talk about today with the opioids are the mu receptors. So the connection between the fuel tank and the nucleus accumbens is called the mesolimbic pathway. So the automatic area of the brain is where we have the reward center. So what is the first substance that we all became addicted to? Sugar. Sugar. So I use this as an example because it's very relatable. So if you have a piece of cheesecake and you like it, then you're going to make dopamine, right? Because you want to remember that experience. So we have to be able to lay down a memory of that experience, and that happens in the hippocampal region of the midbrain. So this is all happening in the automatic area, right? It is not happening in our reasoning, our executive thinking area. So that's a very important distinction. So when this area gets hijacked, right, by a substance, it's in the automatic area. So when we were evolving, we really needed this area to this function of remembering things and liking things, because we had to want to eat, we had to want to drink water, and we had to like reproducing. So when we were evolving, nobody really thought back then, when this was all happening, well, someday there's going to be fentanyl, and that could really complicate things, or alcohol, or marijuana. Okay, so what happens? When we have that cheesecake, and we have an intact brain, we not only have that going on in the reward area where we want to remember the cheesecake, but we have these other pathway up to the reasoning area called the mesocortical pathway, and that is going to create this loop of, well, I like cheesecake, but how often should I have it? Is it good for me? Is it a hassle at the Cheesecake Factory? What flavor do I like? We're going to go through a process. And why? Because the midbrain is still attached to our executive thinking, and as humans, we have a very well-developed cerebral cortex. And the prefrontal cortex, the front of it, is the area where these fibers are attached. The problem with starting the use of substances early in childhood development is that all of these pathways aren't fully developed yet. So it has a much more profound effect when we have a brain that's still developing. And that's with tobacco, marijuana, alcohol, anything. Okay, so we have a fuel tank full of dopamine. We can't let that get empty because we need to have at least some to get out of bed in the morning. So this is the seesaw of my executive thinking battling with my midbrain, and my midbrain, the limbic region, is saying, let's go. And my prefrontal cortex is saying, wait a minute, we got to think about this. So that when people have issues with addiction, it's always kind of the seesaw of who's going to win this battle. And obviously, if the limbic region or the midbrain is hijacked, then it's a much more difficult decision between who's going to win on the seesaw. And just as a aside, the prefrontal region, well, when Freud was doing his original work, it was really not about substance use. It was more about obsessive compulsive people who couldn't enjoy their lives because their prefrontal was dominating, not allowing them at all to be able to enjoy life and use their limbic region that wanted to have more fun. So when they used psychoanalysis, the whole idea was to try and shrink the influence of the prefrontal region to allow someone to be able to enjoy life a little bit more. And that's why they're psychiatrists called shrinks. Because originally, it was about shrinking. The problem with that was the last thing you want to do when someone has a hijacked midbrain that's off to the races all the time is to shrink the executive part that's saying, wait a minute. So originally, before we had medications like methadone and buprenorphine and naltrexone, psychoanalysis was a complete flop to try and help people with substance use disorder. So at that point, everyone thought it was hopeless. If psychoanalysis didn't work, then it was hopeless. And by the way, Freud did have a cocaine problem. Yes, he did, and it was he did a lot of his psychoanalysis on cocaine. Okay, so the next analogy that I want to show to you is that mesolimbic pathway between the fuel tank and the nucleus accumbens. Think of it as a runway, right? And what happens on a runway? Well, you have planes that land, and that plane is labeled heroin. So every time you use, it starts to cause some damage to that pathway, that mesolimbic pathway. And we all know that every time we land on a runway, you hear that, which does cause some damage. We can continue to use it, but the more times you land, the more damage you have. And that is fairly analogous to the more times you use a substance, the more damage that happens. And then you have fentanyl. Okay, so fentanyl, as we heard from the panel, it is a synthetic opioid. So the difference between opiates and opioids, opiates are the naturally occurring compounds from the poppy plant. Opioids are anything that is synthetic or made in the laboratory. So why is fentanyl so popular now? Is because it's a lot easier to make this with a chemistry set than have to go to Afghanistan and find poppy plants and peel them and actually get the real product. But when someone's using their chemistry set to make this, so fentanyl is also an anesthetic. Now, the fentanyl that's used in the hospital that we use in surgery, that is made by a pharmaceutical company, and it's obviously FDA regulated, and we know exactly what's in it. The fentanyl that's on the street is anybody's guess, right? And every time someone synthesizes some, there could be different product. It is 50 to 100 times stronger than heroin. And then there's carfentanil, which is 1,000 times stronger. And then there is a sufentanil, which is now used on the battlefield. So it was just approved, and it's also for pain relief, but it's very powerful, very powerful. So what I'm seeing now in our clinic in South Palm Beach County in Delray is just about 100% fentanyl on new intakes. Rarely see heroin. And the problem, we understand that, so we look for it. The problem is on most drug screens, they don't test for fentanyl. And because fentanyl is produced by somebody's chemistry set in China or Mexico or here in the States now, the different analogs, or it could be different enough where it won't test positive. So it just makes it a little more difficult for us treating patients to know what we're treating. So the good news, though, is you can kind of resurface your runway if you can get control of the use, of the illicit use. Okay, so here is our really important neurotransmitter, dopamine. So to give you an idea of, okay, so what are the levels of dopamine? And how do I know whether I am under or over? Okay, so just to wake up in the morning, it's about 50 nanograms per deciliter. And there's a little d there to kind of represent that that's kind of baseline. Normal day, 50 to 60 nanograms per deciliter. Okay, so it's a very tight range, which is true of all of our hormonal systems, really, is it's very tightly regulated if things are normal. So having sex will double, all right? And someone usually asks me, well, does it matter who you're having sex with? And that's why I put orgasm, not who you're having sex with. Best day ever. You win the lottery, you get to 100 to 120 nanograms per deciliter, which is, again, that's huge. That's doubling. And then you find out that, well, unfortunately, 1,000 other people won, and now you have to go to work. You go right back to 50 quickly. Okay, so heroin. (900 nanograms per deciliter). All right. So that obviously, right, when we're talking about that reward pathway, and we're talking about what's reinforcing, right? So it is the response to the substance. So cheesecake or a fantastic meal will also get you to about 90. So that's pretty reinforcing. But 900? And then crystal meth. 1,200. But crystal meth is metabolized very quickly. So you get this incredible surge and then a decrease. But the reason that I think it's important for me to show you this is so you get an appreciation for why are these substances so reinforcing. Okay, so let's talk about if we have 100 people that try one of these substances, what percent will wind up with a use disorder? So if you look at all the data from around the world, it's somewhere between 15 to 20% of people who try an opioid or other illicit drugs will wind up wanting to repeat the experience. It will be that reinforcing. So I always ask on initial intake, do you remember the first time that you ever used an opioid? And the patients that can tell me the day, the date, what they were wearing, and that their world, that was the first time they ever felt normal. Right. Now, that is profound. Because if it's the first time you ever felt normal, and you have this type of reinforcing numbers, you're going to want to repeat that behavior. So it becomes a medical problem because you've now hijacked that limbic region, the midbrain, and you've hijacked it, and this is the first time you felt normal, so you want to repeat that behavior. And we'll talk a little bit about why this vulnerable population, why that happens, or why we think that happens. The other issue is how you ingest the substance. And the reason I put this up is because a lot of people think that injection or IV use is the most reinforcing, and it's actually inhalation. So that's why tobacco, nicotine, is so reinforcing, because the lungs have these very small alveoli, but a huge surface area, because that's how we get oxygen. So inhalation, or smoking, is the most reinforcing, and you get the incredible high. Injection, then snorting or snuffing, and then ingestion. Ingestion is the slowest because it has to be absorbed, it has to be digested. There's a first pass through the liver. The liver is responsible for detoxifying anything that it shouldn't happen or shouldn't be ingested. So that's the slowest. Okay, so let's talk about our nucleus accumbens and our receptors and what happens with use. So these are the mu receptors that I mentioned. Right? There's mu, delta, and kappa, but it's the mu receptors that are important for this. So if we put heroin in the system and we have this dopamine response, and we're getting this reinforcement because we have the dopamine response, which lays down that memory in the hippocampal region. And if anyone's ever had food poisoning, you will not want to go near whatever you had food poisoning to, and it can be decades, and you still don't like that food anymore. Or as an obstetrician, women who like something during pregnancy and may never like it again after. Because the hippocampal region where we remember these things, the memories are laid deep and strong. Okay, so with increased use, we get more reinforcement, more dopamine, more memories laid down. So what is the body's defense mechanism to prevent the dopamine depletion? Right? The VTA, the ventral tegmental area, is the fuel tank. And I've been hammering that we have to have dopamine to get out of bed in the morning. So the body has a defense mechanism not to deplete all your dopamine, because at a response of 900 nanograms per deciliter or 1,200 nanograms per deciliter, you can deplete it pretty quickly. So what happens is the body just normally will recycle the receptors that are on its surface. We'll kind of like refurbish them and then put them back on the surface of the cell. So this is just a dynamic process that happens all the time. Whether it's a cholesterol receptor or it's a mu receptor, it's the body's way of regulating. So then what happens with chronic use? With chronic use, we wind up having a big dopamine response because we still have a lot of dopamine around. But then the body says, you're depleting my dopamine. When I recycle my receptors into the cytoplasm, into the center of the cell, I'm not going to put all the receptors back up on the surface because I can't have my dopamine go to zero. I can't have my fuel tank go to 0. So what's the response of the person that's using? I'm not getting my dopamine response anymore. I'll use more drug. Right? And that is tolerance, right? But you're probably familiar with, where you try to use more drug, but the body only puts up fewer receptors so it can protect itself. So when people start using, they get this euphoric response, but after chronic use, it's really not about getting that euphoric response anymore, because you can't. It's about using to prevent getting sick from not using. And we'll talk about withdrawal. So why tolerance is important is because if someone winds up in a situation where there's abstinence, and that's usually incarceration or an abstinence-based treatment program, then the body hasn't seen the illicit drug for a while. It puts all the receptors back up because it hasn't been stressed. And what does that set us up for? When you go back to that higher level, when you were trying to get the response, overdose. So coming out of incarceration, there's a 7-fold increase in fatal overdose, because you lose your tolerance when you're incarcerated, and you come out and you start at that same level and you have a fatal overdose, unless you have naloxone easily accessible, which everyone should. I mean, naloxone should be everywhere. Okay, so I tried to set up for you what happens, the neurobiology of addiction and what's happening in the brain. Okay, now let's talk about how we treat them and how successful we are treating it. So you may or may not be familiar with the terms full agonist, partial agonist, and antagonist, but I'm going to walk you through it. So a full agonist means that the medication, and methadone is a full agonist, when it sits on that receptor, right, that U receptor, it fits perfectly, similar to heroin, but it is a different chemical formula. So it sits perfectly, it's a full agonist, and it turns the receptor on about 70%. Heroin turns it on. If it was a dimmer switch, heroin would turn it on, or an opioid would turn it on 100%. Methadone, because it was formulated not to turn the receptor on, to fool the receptor, it turns it on about 70%. Buprenorphine, which is the active ingredient in Suboxone or Subutex or Subsolve, it is called a partial agonist because it only partially fits in the receptor, and it only turns that receptor on about 40%. And naltrexone, which is also Vivitrol, that's a monthly injection, is not an opioid, and it is a complete antagonist or blocker of the receptor. Okay, so let's do a slightly deeper dive into the differences. So heroin, full agonist, big D's, because it turns on that receptor 100%, and you get that response. Methadone, 70%, you get a smaller D, but you are getting a dopamine response. Now, methadone, it was originally synthesized for pain relief as an analgesic, and methadone has a unique way of blocking a different receptor called the NMDA receptor, and that blocks the pain transmission. It also blocks the euphoric response. So whereas with heroin, you get that euphoria and you get that excessive dopamine response, methadone, you don't get the euphoric response, but you do get the receptor being occupied, so you don't get withdrawal. So that's why it's such an effective medication, because it is fooling the receptor into thinking that there's an opioid there, and it is an opioid, but it is just a structurally different one, so it's protective. And then to even have a better advantage, Suboxone, and Sublocade is the monthly injection of Suboxone or buprenorphine. That is a partial agonist, as I showed you in that previous slide. So what does that mean? That means that you get a little D response, only 40% of the receptors turned on, but it has a protective mechanism of what we call a ceiling effect. So what does that mean? Well, that is really important, because you all know that the more heroin you use as a full agonist, you get respiratory depression, and that causes overdose. Well, with methadone, you will also get that type of response. So if you use enough methadone, you can suppress respiration. Whereas Suboxone was designed to only turn that receptor on 40%, so you get a ceiling effect when it comes to overdose or respiratory depression, where you can, with increasing doses of buprenorphine or Suboxone, you do not get increasing respiratory depression. So Suboxone has a very, very important protective effect. The other important part about Suboxone is has a greater affinity or stickiness to that receptor, right? So it won't be displaced by heroin or fentanyl or other opioids. It will preferentially stick in that receptor. So that is very important. So if someone's on Suboxone and they hook up with some old friends and they want to use, because remember, addiction there is this physical part, but then there's the behavioral part. And the behavioral part has laid down those memories in the hippocampal region, and there are parts about it that they enjoyed. And the brain is saying, hey, remember, we like that. We used to go here and do this. We want to do it. If that happens, and it's not uncommon, the Suboxone will have blocked the receptor and prevented the euphoria and the potential overdose. So it's actually a protective effect of having buprenorphine for preventing overdose. And then we have the naltrexone or Vivitrol, and that is a complete antagonist or blocker, but you notice there isn't any dopamine effect. So what does that mean? Well, it's really important, because people have to be motivated to continue on medication. So someone who has an endogenously low dopamine, so they don't have that 50 nanograms per deciliter, they may be at 45 or 40 or 25. The reason that the original opioid use was so reinforcing is because it got them above the normal range, but into the normal range, and then above. So someone who really needs some extra dopamine stimulation, it's very difficult for them to continue on the naltrexone, because they're just not getting the sense of well-being that they were getting from the opioid, or you get from Suboxone or methadone. So, it's complicated. It's complicated, but that's one of the reasons why it's harder to keep people on naltrexone. The other problem with naltrexone is, to start it, you have to be opioid-free for 7 to 14 days. Now, there's ways that I can kind of push things a bit, but because if naltrexone sees any opioid on the receptor, it will kick it off, and you get a very bad precipitated withdrawal. That also happens with Suboxone, with buprenorphine, but that's only a 12 to 24-hour window that you need to be opioid free. So it's just more difficult to get someone started on naltrexone. That's not to say that it doesn't work. It does. And I'm going to show you the data on that. Okay, so let's talk about the data. So if we look at abstinence alone, it is a fairly dismal, it's about a 10% relapse prevention, meaning 90% of people relapse. Now remember, I'm talking about the 15 to 20% of people who have tried. We're not talking about 100% of people that have tried, because for most people, using an opioid is not a reinforcing experience. In fact, it causes nausea. And yes, it will help with pain, but there's nothing reinforcing about it. In fact, it's an unpleasant experience, and you want to stop it as soon as possible. So for most people, you go to the dentist, you have a tooth pulled, you get a Percocet, or you have a surgery, and you get a Percocet. You don't want to take it longer than you have to because it's just not a pleasant experience. The problem is that physicians have been prescribing, a month supply, and then most people take it for a day or two, and then you have this whole bottle of pills that are lying around, and most people don't throw them out because they think, well, someday I may need that, And then, so, the most common source for teenagers starting on opioids or trying opioids are the medicine cabinets of their parents or friends' parents. And I had a patient once who became a realtor just so that they could go to people's medicine cabinets. Okay, so abstinence is not good, And when I mentioned that alcohol, we have 90,000 deaths a year. Less than 10% of people with alcohol use disorder are on medication. And the medication that is most effective is the Vivitrol, naltrexone, for alcohol use disorder. So we're not very good at getting people treated, and it works very well with alcohol use disorder. Okay, so how good is methadone? Well, methadone is very good. It's a 70 to 80% relapse prevention. So it's a 7 to 80% effective. The problems with methadone, as most of you know, is methadone clinics are highly, highly regulated by state and federal. And most people dose daily before they phase up to get take-homes. So it just becomes very difficult logistically. But if you do comply, being that you do have to go every day, then compliance is very high. And with that, you also have to be in treatment and seeing counselors and working on the behavioral part of it. So that's why methadone is a very good medication, but besides that, it's very tightly regulated. So compliance, if you go, is very good, and success is very high. Suboxone or buprenorphine is 60 to 70%, and it's not that the medication is less effective. It's just that it can be prescribed by a physician with a waiver. You need a special waiver on your DEA. But once you have that and you can prescribe it, then someone can get a monthly or work up to a monthly supply so that they really just take the medication once a day or twice a day, but it's at home. You don't have to go dose every day. So it's compliance-wise, it's easier. And remember that the graph I showed you about having that ceiling effect, it's also very protective against overdose should you use on top of being on the buprenorphine. Now, naltrexone is not quite as good, 25 to 50%, so the 25% is with the oral, just taking it every day, and the reason is, as I said before, someone has to want to take it every day. And if they're just not getting any type of effect, then it's just compliance goes down. Whereas if you're on the once a month injection, then you don't have to worry about compliance, and then it goes up to 50%, so much more effective. Okay, so the next important topic for you to be exposed to and hopefully appreciate is the genetics of the vulnerability to becoming addicted or having a use disorder. And we think that it's somewhere around 50 to 60% of people who wind up with a use disorder have a genetic vulnerability to that. So as you all remember from your molecular genetics courses, and again, I'm using illustrations rather than technical medical diagrams because I want you to kind of have an appreciation. So the thread on the spool is DNA, and your DNA is usually tightly wrapped. So it's not exposed, it's kind of tightly wrapped. And they're called histones. Okay. Everybody's familiar with adverse childhood experiences or events, ACEs? Extremely, extremely important for the genetic vulnerability. When I went to medical school 100 years ago, we didn't know that your genes could change with environment. We thought that you got half of them from your mom, half of them from your dad, and whatever you got, that's what you played with your whole life. But it's not true. And that makes sense, right? We have increased cancer in certain areas from environment. So it becomes extremely important to how a child experiences growing up. And there's nothing that could be more devastating to a child than separation from a parent. Right? So there's an experiment going on at the border about that cohort of kids that are separated from their parents and seeing what happens to them longitudinally, because we know that separation from a parent, and we know that from rat studies, that when you take the baby away from the parent, that their epigenetics kicks in and they have changes. And their vulnerability to being addicted, and we usually use cocaine for the rat studies because it's just easier. So very, very important. So what I like to say is that 100% of people that have trauma or traumatic experiences don't become addicted. But people who have a substance use disorder, 100% of them have had traumatic experiences. So some people they just have a more protective mechanism and don't wind up with that. But when we talk about self-medication, that's kind of what we're getting to, is that someone has had enough traumatic experiences. So what does that do? Well, if we look at our DNA becomes more loosely wrapped, so now it's exposed to the environment or the milieu, right? Because whenever we are under stress, we make stress hormones, and everybody knows that, fight or flight, blood gets pumping. So an adverse childhood event will wind up working on a certain part of the DNA that will turn a switch on, and then and one of the examples with the rat studies is delta phos-B, which is a protein, and we know that protein starts to cause more branching in the neurons in the brain, and that increases vulnerability to substance use and substance use disorder. So we're pretty comfortable with the fact that adverse, traumatic experiences growing up can lead to this increase, and that's what we see, and that's what you all see. Okay, so what kind of analogy can I use for withdrawal? So withdrawal happens in the locus coeruleus, which is a part even deeper to the midbrain. So if you think of withdrawal as a million screaming babies, and withdrawal from opioids it's not lethal, won't kill you, but most people wish it would when they're going through it because it's that uncomfortable. So if we use the analogy of what happens between illicit drugs, which is more like breastfeeding or a bottle, which does cause dopamine release, right? That's very reinforcing, and it should be, versus when we use medication, which has been designed to sit in that receptor and fool that receptor, it's more like a pacifier, right? It will stop the crying, but it won't cause that same type of reinforcing dopamine response. It's just temporary while that pacifier is there. And I will mention now, as an obstetrician or just someone who's involved with addiction, is any pregnant woman should be on medication throughout the pregnancy and into the 4th trimester. Because stability is the most important part of that baby not having severe neonatal abstinence syndrome or withdrawal. And what we don't want is the mom and the baby to go through withdrawal continually during the pregnancy. We know that's very destabilizing. So if someone's on medication, whether it's methadone or buprenorphine or Suboxone or even naltrexone, we know that those kids do well and they experience either none or a few days of withdrawal or neonatal abstinence syndrome. Whereas if someone who's using throughout the pregnancy, those are the kids that are born prematurely and wind up in NICUs for weeks or months. So it's very important that as soon as someone is diagnosed as being pregnant, that they get into treatment with medication. Okay, so this is just stuck. Oh, there it is. We can go through this quickly, but because everyone here in this audience, I'm sure, is familiar with, we don't use pejorative, stigmatizing language. Addiction is stigmatizing enough. We don't like to use that. We use substance use disorder, not addict or abuser or junkie. And Dr. Shopper is a patient seeking treatment. Substance use disorder. Problem, it's a disease. We don't call diabetes a problem. We call it a disease. We don't say habit, we say addiction. We don't use clean because it's not clean or dirty. It's in remission or recovery. Relapse is pejorative, so we use recurrent use. And with urines, we use negative or positive like we do with any other lab test. We don't call other lab tests dirty. And we don't use substitution therapy. We use pharmacotherapy. The stigma of addiction, obviously on the individual level, internalized, the environment, everyone around you, and then institutionalized. So we have to get to a point where everyone understands that substance use disorder is a medical problem with a behavioral component for sure, but it is a medical problem. And when treated medically, I showed you how well patients can do, right? So 60 to 70% retention in treatment is great. If you look at diabetes, it is 60% of people with diabetes actually pay attention to what they're supposed to do and wind up having a normal A1C or blood sugar. Same thing with hypertension. So it's not unlike those other chronic medical conditions. For people in the audience that have to worry about the DSM-5 criteria, I'm sure you already are familiar with it if you have to bill or diagnose and use these diagnoses, but it changed with the DSM-5 so that it's now 11 different criteria, and it could be mild, moderate, or severe. So to wrap up, what I started with is that it is a complicated disease, but it's a chronic disease like diabetes or asthma or hypertension. The bio part of it, I take care of with medication. The social part of it is also critical, housing and jobs and not being stigmatized. And then the counseling to really work on the behavioral part, because again, the memories, the adverse childhood events, all that has led up to where that person is now is part of what has to be addressed to have a more successful, sustaining sobriety. So medication, counseling, motivational interviewing, and then fellowship. We always encourage fellowship and fellowship meetings, especially with alcohol use disorder. Housing is a huge problem. I treat the at-risk population, so it's the people who have run out of insurance or didn't have insurance, and it's very difficult to get housing or safe housing because there's been a huge abuse of the treatment centers, and especially in South County. I don't know in this area, but it's been a huge problem trying to get people placed because it's very difficult. I mean, it's difficult enough to climb out of the use disorder, and especially if you don't have a safe place that you can live. Okay, so I will open it up to questions. There's usually questions about methadone because it's so highly stigmatized. Yes? Excellent question. So how long should someone expect to be on treatment? So everyone has come to it with different use of different illicits, which we never know what they are, for a different amount of times, and they have a different genetic predilection. So it's not a one-size-fits-all by any means. And we don't have a lab test where we can say, okay, you're going to be a 2-year. So it's about stability. What we think is a reasonable assumption, and what has seemed to work, is for every year of use, a year of pharmacotherapy. That's just a general. What we do know is short-term use is not successful. And it makes sense, right? No one with a brain disorder winds up with a quick recovery, right? Because the brain just doesn't recover quickly. So the most important factor is not how long you're going to be on it, but how well is your life going, how stable are you, how well are you functioning. And then at some point, yes, there is a time where you can start the discussion of tapering. The important part of tapering, which we know, is it can't be done quickly. Again, because the brain doesn't react well to anything that happens quickly. So everyone's an individual, and everyone gets tapered in an individual way. But we do know if it's working, because if taper from 100 milligrams of methadone to 95 milligrams of methadone and everything is fine, and a month later to 90, and then they're not sleeping, having stuffy nose in the morning, well, then we know, well, that was too quick. Go back to 95, wait another month, and then go to 90. So every person is kind of their own control. And if it's approached that way, just caring about how well the patient's doing, then tapering can be very successful. Great question. Do you have a It's by definition, a chronic relapsing disease. So that's always a concern. Same thing with alcohol use disorder. Same thing with smoking, right? People constantly quit. And you know, the nicotinic receptors with smoking, that affinity is along the lines of opioids. So to stop smoking without medication to get on those receptors is very low success rate. But we have varenicline, which is a very effective medication, and nicotine replacement. So, yeah, I mean, same thing. It's the same thing. It's just that it's not as stigmatized. And for my thoughts on the vaping is if my presentation was on this thumb drive. So whoever thought that you could smoke a thumb drive and nothing would happen, I don't understand it. You know, it's oh yeah, we'll just light this up, and we'll see what happens. You know, but I think that the vaping is, as a nicotine replacement, it worked. But then they went with the flavors and trying to market to the kids. I think that's all going to go away. But the tobacco industry is so strong that it's really hard to. Yes.
What about drugs like crystal meth? Are there medical the same medication?
Yeah, unfortunately not. There's a lot of experimentation going on. How that works is a different mechanism. So it makes a lot of dopamine, but then the dopamine normally gets reuptaken back into the cell, so it could be used again, kind of recycled and used again. Well, what the meth does is it blocks that pump also. So not only are you making extra dopamine, but you're not taking it up, so it's just sitting there. And we just have not had really successful. So that is behavioral intervention, but it's very difficult. It's very difficult. It's so reinforcing. It's a real problem. Yes. It tends not to be unless someone is acutely detoxed. So, a real problem, as I mentioned, is incarceration. So, being that methadone is not available in jails, and actually only 1% of jails in the country have medication programs. So when someone goes in, they get acutely detoxed, they'll go into acute withdrawal, they are sick, really sick for days, and then if they get released, then if they, I've had 3 this week that we were in the Palm Beach County jail, were acutely detoxed. I called the medical director, I tried to get them switched on to buprenorphine. It took 7 days for that to happen, and it's really cruel, unusual punishment. But if someone's acutely detoxed, then the overdose risk goes way up. If someone is tapered, and then they relapse, their risk is not as high, but that it also depends on what's on the street.
I'm sorry, we have to cut off questions because, and Dr. Schlosser, thank you so much. He has an extra. He just came back from New York. Thank you for doing that. But we're hoping that he will come back in the spring for one of the other presentations. I